What?
We're live.
Do we have to do that? Okay, I won't natter as much anymore. Okay, so as I said, this one is, we're going to start with this one. It's quite interesting because I'm into spelling correctly, and there's a lot of misspelling, so I'll just leave it at that. And find it at your leisure. This is the first one.
You just took at him, Jeff.
Don't worry, I correct the nurse's spelling too. It's okay. All right, so let's talk about this. I thought this was kind of cool to start with, but this just shows all the different things you're looking for in your X-rays. You're looking for the metal, which is the whitest portion. Now I'm not doing anything here. Okay, the metal. Then you have plastics. You have something probably compact or something like that. I'm talking too slow. Just a minute. Okay. Now you see. Can we keep the lights down? I'm sorry. It'll be easier to see, and you can go to sleep too. You know, it's like okay. I'm not testing on any of this. Thank you. Okay. You can see bone density versus metallic density. Huge difference. And this is also soft tissue. Okay. Those are all the important things you really need to know about X-rays. Okay, let's go this way now. I wasn't able to read this when I'm on the computer, and I'm still not able to read that. X-rays. Any questions? Good. All right. So we're going to start with basically the chest X-ray. Okay. It is very easy to look. All of a sudden, you're looking for the pneumonia, looking for the pneumothorax, you're looking for the fractures. Well, if you do it in a systematic approach, you're going to find it a whole lot more, much faster and much quicker. And you might see hundreds of X-rays and not see anything real. But bottom line, looking at bony structures first, looking at symmetry, looking at the size of the heart, you know, all of those things you have to very carefully go through. And how many people have done a whole lot with X-rays? Anybody? Okay, that makes it easier. All right, so I was always taught to start and do it the same time, every time, the same way, every time. Looking from the right to the left, looking at to see the clavicles, how they are, the rib cage, just a quick look. I'm just saying symmetry, symmetry. Then you're looking at the lungs. You're looking at you look at the soft tissues pretty much at the end. And you don't see any metallic fragments. You don't see anything white metal. So you're looking at the bones, then you look at the lungs, and you start at the top and go up each side all the way down, and you look at the heart margins. As I said, same time every time. If you guys want to come up closer, doesn't really bother me. You want me to move it?
No.
Then I can put that here and then move the podium. Would that be easier?
It'll be all right.
Okay. All right. So as I said, same way every way, then you don't miss the big stuff. Oh, this is interesting. This wasn't in mine. Okay. This is great because it shows metal, it shows bone, it shows soft tissue, and then it shows air. Air goes directly through and it's very black. You see the soft tissues of the hand. Obviously, you see the metal. I think this is a different slideshow than he sent me. Cool. Any questions so far? Okay. So it doesn't matter which one you use, just stick to one. So you look at the same X-ray every time the same way. And I've heard that time and time again when I was in training. You would not believe how much that has come to pass in the last 30 years. And it's because basically you're going too fast. Everybody looks at the one thing and then they've missed all the other stuff. And there's a couple of ways to prove that in here. So this doctor has a checklist. Okay. The right person. That has been a huge problem over the years. you might be looking at Mr. Jones's X-ray, and it's actually Mr. Smith that you're looking at. So look for the right person. It's just the same like the timeout every time they do it in surgery, anything like that at all. Right person is the right side and the left side is marked correctly. You would think that with a chest X-ray, everybody would know which one was the right and which one was the left. There are some X-rays in here you can't tell. Is the patient rotated? Because if the heart looks huge, is it because they are rotated and you're seeing the side of the heart versus the AP or the anterior posterior portion of the heart? Radiation. Okay. All right. Now this one is kind of interesting. This, they say, is a 25-year-old male with a complaint of pleuritic chest pain on the right side. Okay. I'm just going to give you a couple of seconds. I know you don't look at X-rays regularly, but is there any reason why this might be, you're worried about one of those R's? Right person, right or left, rotation and radiation?
It's like the heart's the wrong way.
Well, the heart is actually, it's a little globular, but it actually is okay. The soft tissues are okay. You see that on the top portion there, it says that's the right, so you know that's the right side. You look at the end of the clavicles right here, and it looks pretty even, so the person's not rotated. But this a 65 or 25-year-old male, there's one small problem, and then, as I said, these are the things you start looking for. These shadows right here, what are they?
Breasts.
Bingo. This probably isn't a 25-year-old man. So as I said, you still look at the same things, but if you still look at it, okay, this is the right side, this is the right person. Well, that's not the right person, but it's a pretty good example. So at this point, looking at the, you're still looking the right and the left. You're looking at, because there is no R, or if it is, it's crossed out right there. But you look for that. You look at the bony structures. Just very briefly, you can look at the bones much later. If you are really worried about the ribs, you are not going to use it on a chest X-ray. Chest X-ray is a very poor way to find rib fractures unless they're very significant. So you're looking at the soft tissues, you're looking at the diaphragms. As I said, just start making a plan. Looking at the apices of the lungs bilaterally, just real quick to see if there's anything going on. You look at the diaphragm. In the other presentation, they say that the diaphragm is 100% always higher on the right. That's not true. It's about 95% because some people have congenitally higher right diaphragms. Also, things that happen if you have a pneumonectomy and they remove the entire lung, your diaphragm might be a little changed. Okay. What's wrong with this one? Sorry?
Looks like it's taken posterior.
Okay, could be. Is this the right side or the left side? Can you tell? The heart doesn't look correct. Somehow it doesn't look right. Is that because something's going on, or is it because it's backwards? They flip the right and the left. So you look at the top, and all of a sudden you see all this blackness. When it's this black, you're looking at air. This portion right here is the left lung. And this is a tension pneumothorax, okay? Because you have your right diaphragm. Your left diaphragm is deeply compressed. It's not a nice little hump. It's sort of like flattened out. But I have known people that with this, they put a needle in the right side because the X-ray was flipped. It is a little harder to do now than it used to be. It still happens though. And you hear about all these people that are hurt or injured because of the hospitals or because of medical error. This is an easy medical error. You're running around, you don't know if that's what this is. All of a sudden you see the tension pneumothorax and you throw the needle in the right side. And all of a sudden you have a little bit of a problem. because if you put a needle in this person's right side, he might not have either lung inflated. Okay. It took me a long time to figure out what these two arrows were pointing at, because I was looking for air in the mediastinum. I was looking for all sorts of weird objects, but they're actually pointing out, oh, come on, is the clavicles, the ends of the clavicles. What they're wanting to show you is that it's pretty much centered. Okay, so you know the person is not rotated. This is a pretty good chest X-ray. On the other hand, this one, if you can tell which one is right or left, I'm not quite sure. Okay, and is this heart huge? Is that the right side? Is that the left side? Some tips might be that his pacer is usually on the left side. Okay, so is this just rotated a little bit? And then that's what they're trying to show you here, is that there's one clavicle and there's the edge of the other one, but he's markedly rotated. And it also happens to be, that's the left side. So as I said, once you learn normal, abnormal looks a little bit easier. Thoughts?
Redo it.
Okay. All right. That works.
Watch it turn on too bright.
Yeah. Was this underpenetrated? Was this a bad X-ray? Well, actually, this may have been a bad X-ray. And that's a little bit overpenetrated. Okay. So can you tell that does he have lung up there? It's not, or she, I'm sorry. If she has lung up there, it's kind of hard to tell. Does she have bilateral pneumothoraces, or is this just a bad X-ray? The other thing that this darkness could be is if you've ever heard about blebs at COPD, people have large pockets of air, and sometimes those blebs break open, and then they can develop a pneumothorax. But we're almost done, Lee.
Whoa.
We started early. Okay, so this person recommends the checklist. Looking for the airway, looking for the aorta, breathing, bones, circulation, like everybody else, A, B, C, D, they like to use all of this stuff. That's your call. But finding a way to look at X-rays real quick. As I said, I'm going through this fast because I'm not trying to show you how to do X-rays, but if you just do a systematic approach, it might help. Okay. Airway. What we're looking for is, number one, is the trachea midline. Okay. You look for the clavicles. Can you see the trachea in the midline, or is it off to the side? Is it rotated? Is the person, as I said, once again, we look for right versus left, the right person. We look for pathology. We look for the tension pneumo. Here, this is a carina, not a corina. Okay. And when you're placing your ET tube, you're trying to put it right above the carina. Okay. It's so easy to put it into the right main stem, then all of a sudden you're not aerating the left side. Another thing, I think there's a good demonstration of croup in the other series of X-rays where it shows steepling, and I'll show you that in the next slide series. There's 160 some odd slides, 170 slides. Okay, looking for the knob of the aorta. Is it on the left or the right? It's very easy to say that it is always on the left, which is also not true because you have people who are born with situs inversus where all their organs are rotated. So then before you decide what you're going to do about that, you ask that person what's going on, and if it's a problem, if the X-ray is rotated, it's hard to tell. But you always want to find your left main stem bronchus. That's where your aorta is located. Calcifications, you're probably not looking for calcifications in trauma, okay? Calcifications go with things like, well, you have the metallic objects like your hatchet, your bullets, but you have other things too, like your stones, and I don't think you're going to be really interested in that. The size of the mediastinum is important because if your mediastinum is enlarged, you're worried about a thoracic aortic aneurysm. Okay. For those of you who want a review of your anatomy of your lungs, you have three lobes on your right, and your left you have 2 lobes. Okay. Starting to look again. We're just looking for the airway right now, okay? And the airway, it looks like it's deviated slightly to the right. It's not clear because we don't see it all of the way down. Remember your anatomy. Your brachiocephalic artery, the trachea goes behind that, and your esophagus. Your left common carotid, left subclavian, and here is your left mediastem bronchus. Looking at this, that is the aortic knob, okay? You're looking for the prominence of that. You're looking for the soft tissue, the mediastinum. Is this widened? And that is not widened. But starting at the top, once again, you're looking at your clavicles. You're looking at the patient is rotated. You see your midline trachea, which is A-OK. You're looking at your right side and your left side of your ribs real quick. This is a poor way to look at the ribs, but they're pretty even. You're seeing your right diaphragm and your left diaphragm. You notice the crispness right here in the costophrenic angle. The costophrenic angle there, it looks clear. That is a great place to find fluid in an upright chest X-ray. Okay. This is where it gets interesting. Looking at lung fields. After 30 years of looking at lung fields, can I still miss a pneumonia? Sure, I can. Sometimes you will see a person and you say, oh, they have a definite pneumonia. The cough, the hack, you hear it. You hear the wheezing, you hear the bronchi in their lungs. You do the chest X-ray and it's perfectly normal. The chest X-ray isn't wrong. This patient still has pneumonia, but the fact is that sometimes it takes up to 48 hours for it to show on X-ray. The other thing is that in the older patient, when they're in their 60s, 70s, 80s, they're not feeling well. They are horrible at taking fluids. Okay, if they're dehydrated, a pneumonia won't show up. You hydrate them with a couple liters of fluid, and over 24 hours, it shows up 24 hours later, and you see a huge pneumonia. So X-ray is not always wrong. You always have to go with your clinical impression first. Okay. The absence of markings, as we talked about earlier, the possible pneumothorax or Ebola. So you're looking at this one, as I said, looking at the both sides. You see that this is pretty, I would say it's pretty even. You see your trachea's midline. You see your aortic knob with a little calcium here. You see the diaphragms. This one is right here is you like a gastric bubble or colon gas. Not too worried about that. This might be a little wider than normal. Could it be an infiltrate? Possibly. Might be a little atelectasis too, where the lung is collapsed just slightly. Once again, the lobes. Okay. As I said, fractures are real interesting to look at, and sometimes when they're very hard to, you see a bunch of rib fractures, you're looking for the flail chest, you're looking for the pneumo, you're looking for what caused that. Okay, I'm sorry, this is a little different than the one I was given. Okay. I don't know how well you guys can see this here, but looking at this one might be okay. I can't tell about this one, but this one looks abnormal. You look at the cortical disruption right in here and right in here. and right in here. So you might have a flail there. Okay. There's a real close-up of the heart. What doesn't look like it's supposed to be there.
A wire or something.
This is supposed to be a pointer. Let's try this, okay? Yeah, this one right here. This is actually a chest tube. And you can see because here's part of there's a metallic strip in the chest tube and it ends there. So this is a hole. So that's why, that's what I'm looking for when I see the chest tube. It's a little high up, first of all. This one, as I said, I had a hard time figuring out what they were looking at. I think they're looking at how crisp the heart margins are. If either one is shaggy or abnormal, you can be looking for infiltrates like pneumonia. You could be looking for a right ventricular hypertrophy, like a cor pulmonale. But this actually looks very good. What about this one? Mm-hmm. For this one, yeah, it looks like it's a cardiomegaly. You don't know if it's ischemic cardiomyopathy or whatever. But in this one, it's not the greatest picture to see what we would consider curly B lines, which are lines in to look for congestive heart failure. I can see the enlarged heart, and it's markedly enlarged, but I don't. Oops, sorry. What I'm looking for is right in here. You would see some straight lines here to go with fluid or congestive heart failure. And this is a poor X-ray to show that. Okay. Diaphragms. We're looking for the two curvilinear areas. We're looking that the right is usually, most of the time, higher than the left because of the liver. You're looking for sharp margins. And underneath, you're looking for what might be the NG tube, looking for the stomach bubble. Okay, bones, clavicle fractures, humerus fractures, scapula. A lot of people look at the edge of the scapula and think you're looking at a pneumothorax. Okay, so as I said, and rib fractures are some of the hardest things to find because you're seeing a curved bone on a two-dimensional, well, not film anymore, computer. This is his final 4S, is the soft tissues. You're looking for air and you're looking for foreign bodies. Okay. As I said, the chest tube placement right here. And I don't see, and it's hard to see, but this would be the first place you look for a pneumothorax in the apex of the lung. Ali was telling me earlier, because I was saying, well, why would this be such a mandatory portion of your training? Because bottom line, we hand you discs these days. We don't hand you X-rays. And but he was saying that at least if you know that you have a 10 to 20% pneumothorax when you're on the ground, if you're going on the chopper, you have to put the chest tube in before because it automatically, that lung is going to collapse when you're in the air. So, okay. This was kind of interesting because you see, let's see how this see. You're looking at the shoulder right here, but this is supposed to be your scapula, and it should be over here. And the angle of it, I'm wondering how they dislocated this. I had to look at this clavicle, wondering about this clavicle, if that was injured as well as this, because this should be over here. So as I said, a couple of these, Lee, I did not know what they were trying to show. But
that be an anterior dislocation?
Uh-huh. Posterior dislocations are much less common. Most time, posterior dislocation is because of a severe fall or maybe a seizure. And as I said, on projected, it is harder to see some of these things because you cannot see the full scapula in the back. Okay. Well, they're obviously showing you this large object here. This person, I think, is the one that is short of breath, and they're wondering what's going on here. Is this a huge mass that is swallowing up his trachea and compressing his trachea so he can't breathe? This is what they want you to learn: pneumothoraces, effusions, and pneumonia. Okay, so that would be your partial pneumothorax. Did you get anything other than the slides? Because some of them, as I said, I have no idea what they're showing.
So,
I think this is what they're trying to show right here. This looks like, for me.
This guy's obviously had a cabbage.
Yeah, and then,
right.
Oops, what happened?
But then underneath,
yeah.
Let's see. I think it's.
Okay. Let's go back to this one then. Okay. So this is what you're looking for right here. You will see this line, and it's sometimes hard to see if it's this. But this is a pretty large pneumothorax because you see all of this emptiness right here. You see that the lines of your lung parenchyma end right about there. And then you see this nice little, so that this could be a spontaneous pneumothorax. Spontaneous pneumothoraces are more common in smokers and especially young, thin females and males. More males than females. But no, all right.
What would you say? 12, 15%?
I'd say a little bit, even more.
More.
I'd say a little bit more. I'm horrible at guessing this though, but that's a fairly good size. He's going to have a problem. This one is kind of interesting, and this one you have to look at it real closely. Anybody see anything exciting about this one? You mean that?
Yeah.
Yeah, that's something. The other thing, and so that's the impressive part. But then you're looking for that medal, thinking, okay, and some people are good enough to tell me that's a 9mm versus what caliber. I really don't care. But then more interesting is that right here, where's that diaphragm? Is that here? It's real hard to tell because is there lung here?
Does it look like it's flannel chest too?
Yeah. Mm-hmm. And then when everybody's looking at this side, I looked at it on here, and no, you can't tell real well on this one because it looked like there were rib fractures on this side as well. So this is the scariest one because I think I was in Ottumwa at that time, and a paramedic said, a critical care paramedic called me and said he had a tension pneumo and he wanted to put a needle in. And when they're 45 minutes away from Iowa City and going to Iowa City, it's pretty scary because I had to say okay and never heard what happened. But this would be the time you grab your full, I don't know if you guys have a 14 gauge, but put in that second intercostals and what happens. Oh, okay. Other than being overpenetrated, I don't see anything on this one. But once again, he looks like he's pretty even. Here's this. Here's his clavicles. and his first, and one other thing you look for, and this is kind of a weird one, but look for the first rib right here. If you see a first rib fracture, and you can see it on X-ray, you know you have a massive trauma because the first rib doesn't break very easily, just like the scapula. I think I've seen 3 scapulas broken in the last 30 years. One of them was because the person was hit by a train. But, other than that, it's a huge amount of force. And so it's like something to.
With your clavicle, probably have some fractures. You're breaking your first rib.
I'm sorry? Oh, yeah. Because it sits right on top of each other. Okay. Now, and it took me a long time to figure this one out too, because I was looking for, this is the one I was having a hard time too. I was looking for mediastinal widening, and obviously that's not there. I was wondering if there's air in the mediastinum, and finally I came up with the fact that maybe they're just showing that this is it's a midline.
See if there's any notes on it.
See,
Nope.
he doesn't give me notes. He just gives me these. After the 4th time through, I decided to forget it. Okay. All right. I think this is the first lateral we've seen, hasn't it?
Yeah.
Okay. All right. What do we do with lateral X-rays? Lateral X-rays, you're still doing about the same thing, but you look at the bony ribs, or you look at the thoracic vertebrae. Okay. Any fractures? And this is the best place to see the sternum, if you can see the sternum right there. The sternum is very difficult to. You cannot see a sternal fracture on our AP. If you can, you're doing very well and then looking at the sides of the heart, you look for a retrocardiac. This is usually empty. It's a little bit darkened right here behind the heart, and you have a little bit of opening right here in front of the heart too. Okay. This, as I said, it's just basics. You see the diaphragm. You cannot tell if this is the right or left diaphragm from this because you only see the one shadow. So. But actually, there's no evidence of fluid here. So you know that there's no evidence, no blood or no fluid. I think it takes about 250 cc's to show up on an X-ray. Okay. This is a great one. There's very few definites in medicine and in anatomy. But there are straight lines in a body that's very unusual. When you see a straight line, you're looking for air fluid level. And X-rays, so air fluid levels, you're thinking about your bowels, you're thinking about abscess cavities, you're thinking about so straight lines. Okay, so this right there under the diaphragm. Thoughts, guesses?
Air.
Mm-hmm. And so this means that there's fluid. This is where your stomach bubble is, right underneath your left diaphragm. You will notice, however, that look at how the diaphragms are curved downwards. I don't know any history about this person, if it's a trauma patient or not, but I do know that, number one, these are clear, so there's no fluid in there. I'm looking at this. He looks pretty even, but I think they were just showing this. And you will notice that from here to here, that's quite a huge amount of lung field. And you have to think about COPD, emphysema, things like that.
So is his stomach pushing his diaphragm out of the way?
Not necessarily. No, that's actually looks like a normal stomach bubble. But the fact is that the diaphragm, as I said, is pretty deep in here on both sides. So I have to wonder about COPD. Any smokers in the room that'll admit to it? Okay. Okay. This one is a little harder to see, but what you're seeing here is you're seeing small bowel, and you're seeing lots of loops of small bowel. Now the interesting part of this is that this line and this line, it's usually one loop of bowel. And there's one air fluid level here and one air fluid level here. There's one air fluid level here, and you take this all the way around, and this is another air fluid level. Air fluid level here, here's the loop right here. This is a small bowel obstruction. So if you have a large enough amount of air in this, you can push your diaphragms up, and you might just see it on your plain film of your chest X-ray. You see all this extra air. You're thinking, what's going on? Take a quick look at this. You have to have a upright to see air fluid levels like this for bowel obstruction. There have been a couple older people that have had no pain with the bowel obstruction. Anybody like to guess what that air fluid level is?
So would you say?
This one right here. So, as I said, you start looking at all this, but this sort of, this huge, well, is that a mass? Well, when it has an air fluid level like this, you have to wonder about an abscess cavity. Come on. Okay, this is what they wrote. This is not my final exam. We've seen this one before. So you're looking at, once again, the clavicles, the shoulders. You're seeing the first ribs there. You're seeing, here's your trachea. You're seeing this. Don't know quite what this mass is. Obviously, first thing everybody thinks would be cancer. Another thing would be sarcoid. You see his left diaphragm and his right diaphragm there. This is this looks like it's pushed down. I don't know that there. When I looked up here, I was looking for a pneumothorax here. I was like, is this a pneumothorax here? It's not the best X-ray to show. But that would be one reason why this is so low. Okay. This one, this is a little bit, this is not a clear, crisp part border, neither is this one. You see a lot of, I guess haziness would be the best bet. You do not see an air fluid level here, but this is just a loop of bowel. I think that's it. Questions so far? Am I going too slow?
No.
Too fast? Okay, now, I think we should not record this.